This is PediaCast.
Welcome to PediaCast, a pediatric podcast for parents. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast. It is a pediatric podcast for moms and dads. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 533 for February 23rd, 2023. We're calling this one Looking at Your Newborn. I want to welcome all of you to the program. So today's episode is going to be particularly helpful for parents who are expecting a baby or just brought one home from the hospital in the last month or so, and for anyone else who is interested in the unique features of newborn babies. And there really are some unique features, ones that often worry new parents. So, you take them to see the doctor. Your doctor provides reassurance and says, yep, that's a normal newborn thing. And I want to pause here quickly to make an important point. That's okay. So as a pediatrician, you're not bothering us when you do that. We love explaining things and providing that reassurance. Parents are not born with the knowledge of these things, right? And we're here to answer your questions and make sure that everything is A-okay. And there are also some signs that are worrisome in newborns, and you wouldn't know that. So not everything is normal for newborn babies. And your best bet really is, in order to tell what's normal from what's not normal, is always going to be a trip in to see your baby's doctor, or in the very least, a phone call so that you can describe your worry and the medical staff can advise you on how to proceed. Now, that said, there are some very common but unique features that newborns have and that are good to know about. Things like stork bites and angel kisses, scalp swelling, eyes that change color, all sorts of rashes. And we will discuss many of those today. Bulging bellies and belly buttons. Breast development can be normal even in boys during the newborn period. And you might even see a little vaginal bleeding in newborn girls. So we're going to explain why all of these things happen and to hopefully give you a sense of what to expect. What's normal, what's not normal, when to worry. But again, as a new parent, worry is normal, and we are always happy to see and evaluate your baby when you have any concern at all. To help us explore looking at your newborn, our Pediatrics and Plain Language panel returns for a studio visit. That means, of course, that Dr. Alex Rakowsky and Dr. Marianne Abrams will be joining us soon. They are primary care pediatricians at Nationwide Children's. And when they visit, we strive to inform parents in a way that maximizes health literacy while using terminology that all of us can understand. In other words, this episode will hopefully be free of medical jargon, or at the very least, if we have no other choice than to use medical jargon, we'll do our very best to explain exactly what the big or fancy words mean using regular everyday language. That is the goal of these episodes, and we do our best to hold each other accountable in that endeavor. And it actually is more difficult than it sounds. Like, I really try to keep the language at a level that you don't have to have a medical degree or a nursing degree to understand what I'm saying in all of our PediaCast episodes. But we catch each other a lot, and I'm sure that I slip here and there, just like we do in the exam room, which is not good. But it's because there are terms that we use with other providers, with our colleagues, with nurses in the office, when we're documenting in the chart. That's like a second language, and for a lot of doctors, that spills out into your communications with family and with parents who may not have a medical background. And we do our best not to do it, but it is okay from a parent standpoint to, if you don't understand a term, to say, whoa, stop. What did you mean by that? So it's really important that you understand what your doctor's saying. We'll do our best not to use the jargon, but when it does happen, just like we're going to hold each other accountable today, you can hold your doctor accountable as well when you are in the office or talking to them on the phone. All right. Before we get to our friends, let's cover our usual quick reminders. Don't forget, you can find PediaCast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for evidence-based child health and parenting information will know exactly what to expect. We're also on social media and love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And we also have that handy contact link at PediaCast.org if you would like to suggest a future topic for the program. The information presented in this podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. If you have a concern about your child's health, be sure to call your healthcare provider. Also, your use of this audio program is subject to the PediaCast Terms of Use Agreement, which you can find at PediaCast.org. So let's take a quick break. We'll get Alex and Marianne settled into the studio, and then we will be back to explore looking at your newborn. It's coming up right after this. Our Pediatrics in Plain Language panel is back in the house. You will recall that Dr. Marianne Abrams is an assistant professor of pediatrics at The Ohio State University College of Medicine and a pediatrician with primary care pediatrics at Nationwide Children's Hospital. Dr. Alex Rakowsky, also an assistant professor of pediatrics at Ohio State and a pediatrician with Olentangy Primary Care at Nationwide Children's. Let's give a warm welcome back to our friends. Thanks again for being with us today.
Thank you, Mike, and welcome to spring in February. It's 75 outside.
Yeah, so beautiful.
And then it's supposed to ice on Sunday. So it's classic Ohio.
Yeah, absolutely.
Great to see you both.
Yeah, and welcome to the new year. We have quarterly Pediatrics in Plain Language panel episodes scheduled, and we're really excited to bring these to folks. But I think a great place to start is, why is this important? What is plain language? You know, why do we make a big deal out of it, Marianne?
Well, as you know, I always think about this right before we come together for these podcasts, which are really fun to do. And I hope people not just enjoy them, but take away some really good points from them. So in keeping with the title or the theme of our presentation discussion today, which is called Looking at Your Newborn, which is a baby, I thought I'd talk about what plain language is not. And it is not baby talk or dumbing down. So many people tend to use those kind of negative words. Oh, we got to dumb it down, or this is all just baby talk. That's not right. Plain language is clear communication. It uses the number of words that you need to make your point, and it lets people focus on the important content as opposed to deciphering complex words or technical terms or long, convoluted sentences. So using plain language is actually a sign of respect and equitable, equal treatment for everyone, including somebody who may be highly educated but is very worried about their baby or their own health or some other issue.
Yeah. I have glaucoma and see my ophthalmologist on a regular basis, and she sometimes uses jargon that she thinks I understand, and I have to say, whoa, what do you mean by that? Because we each are in our own little slice of medical field, and we're going to have terms that other doctors aren't necessarily going to understand if they're not in our specialty. And I mentioned during the show intro that it's fine if you're not understanding something that your doctor is saying to stop the conversation right there and just say, whoa, what did you mean by that? Just so that you can have clarity.
But by the same token, that is hard to do. I mean, you are a physician, a doctor, and it's a lot easier for a doctor to say, wait a minute, than it is for a lot of other people. And that's why we have a responsibility to communicate as clearly as we can and to make sure people feel comfortable stopping us or asking questions.
Yeah. I would say if a family member stopped me, I would take that seriously. Like I want my patients to understand what I'm saying. So I would encourage families to do that, and I would encourage medical providers to not make your families do that, use the plain language as much as you can.
Or to encourage questions by asking, what questions do you have? Instead of, do you have any questions? Because a lot of people just say, no, I don't have any questions.
Yeah.
But we assume everybody has a question. And by saying, what questions do you have? That tells people that I'm sure you have questions.
That's a really good point.
That is a really good point. Like, don't let them be able to say no. You have to think about it a little bit. I mean, the answer may be no, but you have to use more than one word in response to that when it's an open-ended question. For folks who maybe have not done so before, we do have a survey that we would encourage you to use. It's going to be in the show notes. It's our Pediatrics in Plain Language survey. We just want to get your ideas of what you think about this series within a series of these plain language podcasts. So we would encourage you to fill out the survey, and there will be a link in the show notes. I also want to remind you there is a playlist on SoundCloud with all of these Pediatrics in Plain Language episodes kind of packaged together. And we have covered so many topics, including your child's stomach, their breathing, their mouth and throat, their ears and nose, their eyes. We've talked about fever, keeping kids safe, literacy, fitness, just lots of things. And today, as Marianne mentioned, we are going to talk about looking at your newborn. And one of the first things, if you're just looking at a newborn, that we notice is their skin. And I've always found it interesting. People always say like, oh, you have like the skin like a baby, or baby soft skin. But baby skin is not always a beautiful thing, right? Right, Alex?
No, it's not. Actually, a lot of babies look like they just were in a street fight. And so if you actually... I work in a clinic with a lot of immigrants. A lot of families have come here recently. So last year we had 80 different either countries or regions represented, and everybody's worried about the baby skin. So this is a across-the-board concern a lot of the parents have. So some differences between baby skin and I'm going to call it adult skin or outside of mom skin. You have to have waterproof skin inside of mom because you're living basically in an aquarium, and that's all going to change into the usual more adult skin. So you're going to have peeling of that skin to kind of get into the new skin. So every kid's going to peel at some point in the first few weeks, and it will come either in batches or little pieces. Also, when the baby's coming out of mom, it has to have some kind of lubrication to kind of pass through the canal. So the babies are going to have this like greasy goop on them called vernix, which essentially just helps them kind of slide through. So a lot of babies when they're first born have this like slimy appearance on them, which can freak some parents out. And I still get questions like 3 days, 4 days after birth, what was that? And they're going to have some swelling here and there because they just got squeezed for a birth canal. It's like essentially getting your face squeezed in a door for like a couple hours. You're going to have some bruises on your face. The head doesn't look right. You may have some peach fuzz also called lanugo, which a lot of babies have depending on your cultural background. And then also when all of this happens, when you start producing your more typical outside of mom skin, you get some acne, like rash also. So there's a lot of changes in the skin right after birth and then for this first couple of weeks.
Yeah, absolutely. One of the things that we see on the baby's skin, especially after the first week or two, is some scratches because their fingernails they can scratch their skin pretty easily.
Inside of mom.
Yeah. They may come out with a scratch.
Yeah.
And so trimming nails can be helpful, but that's a scary thing for parents.
It's hard to do.
Yeah. Do it when they're sleeping. And you may only get one finger done per nap, but eventually you kind of rotate through all of them. I want to cover some specific rashes and skin lesions that we see in newborns. And the first one that came to mind is the stork bites. So what are stork bites?
It's where the stork carries you when it drops you off at home. So actually it's these little red rash on the back of the neck. And there's some other terms for it. I mean, scientifically, we're going to call it a nevus simplex or a salmon patch. And it's like this sort of like flat pinkish rash on the back of the neck. You can see it on the front of the forehead when it's called an angel's kiss. You'll occasionally see it on the eyelids also. We tend to associate it with infants, but basically it's a stretching of the blood vessels in that area, and the skin is thin. So you have the stretching, and then you have a thin skin on top of it, so you actually see it. And there are some adults who actually keep this their entire lives. In other words, they may have very fair skin or very thin skin, and they'll have that stork bite on the back of their head forever.
Yeah.
And we actually may all have it. It's just that our skin gets thicker and we can't see it.
Yeah, and we get fat deposited underneath the skin that kind of surrounds those vessels, so you can't see them on the surface of the skin. So they tend to fade, but they don't necessarily go away. They're still there. You just can't see them anymore.
And they're perfectly fine. I think a lot of parents get worried about it. And we'll talk about one that can look like it, which I think you have to be careful that it's not this other rash that we'll talk about or finding. So
yeah. Another common one actually has a new name. We call them slate gray macules. And Marianne, what are slate gray macules?
Well, I think slate gray macule is a name that helps describe what this skin condition looks like, because it kind of describes the color. And a macule is something that's very flat on the skin. It doesn't stick up or out or in. So this sort of describing the color of this flat marking on the skin. The old name for it was a Mongolian spot, and that was probably because in general these are more common and probably more visible on people who have darker color skin. So that's the common name that was used. And then the non-plain language name is congenital, meaning when a baby is born with something. Dermal, meaning the skin. Melanocytosis, which means a lot of coloration. Melanin refers to the pigment or what gives color to the skin. So it sounds kind of awesome and scary. But basically, it's a dark patch. It's not even a patch. It's a flat area on a lot of babies. And it's usually over where their bottom meets their lower back, or sometimes they can have it in other parts of their body. It doesn't cause any problem. It doesn't hurt. It's not a sign of injury. It's not a bruise. Most of the time, they just sort of gradually fade away over a couple of years. You don't even realize it, and then one day it's like, oh, it's gone. Sometimes it will last into adulthood, but that's not common.
Yeah.
So the only real concern is that if someone's not used to seeing that, and sometimes people think it is a bruise and they're concerned about child abuse and wanting to make sure that the baby wasn't injured. And that's why health providers especially, but parents also need to know what this is, that it's normal, that it's been there since they were born, and it's eventually going to fade away.
And I have a quick story from clinic, and the kids when they're born are going to have either like a lot of red color or they have a lot of peeling skin for a while. So you may not notice these CDMs or slate gray macules until the skin becomes nice and smoothed out. So it can be like week 2, 3, 4, and that's when grandma comes, or that's when a family member comes and they say, who abused your child? I've probably seen this a dozen times in the last year where at the 1 month visit, the mom or dad are bringing up, my parents are concerned about somebody bruising the child because they haven't seen it before.
Yeah.
And because it was buried underneath all those changes after birth.
Yeah.
Or sometimes the baby's just been loved on and bundled up and everybody's been taking care of them, but not maybe studying the back part of them. And as you said, the skin maybe is changing a little color and maturing. And it's like, oh, what is this? And who was last with my baby?
Yeah, absolutely. I don't know who is in charge of renaming things. I certainly understand wanting to move away from Mongolian spot because babies of all nationalities, and not just from Mongolia, can have these things. But it seems to me we should have renamed it slate gray spot instead of macule. You know what I mean? Like to keep a little of the old lingo, and spot, I think, is more plain language than macule. So anyway, I don't know like who's in charge of changing names.
slate gray area.
A slate gray area. Because they're large.
Yeah, they aren't.
And when I think
necessarily a
macule,
spot.
I think macule as a physician, I think of something a little smaller than what a slate gray spot. See, I think we need to change the name. We're going to start it right here on PediaCast.
Because your point is a good one, that these can be like 2-3 inches, which is a lot of area on a baby.
Yeah.
So they can be pretty darn large.
All right. Pustular melanosis. What is a pustular melanosis?
That is another common rash, maybe not as common as some of the other rashes that we see on new babies. And it kind of just shows up sometimes when their babies are born. It doesn't last very long. It fades over a few months. And depending on what time in the baby's life you see it, it may look a little different. In the beginning, it may look like little, I hate to say the word pustule, but little pimply things that you can kind of feel and see on the skin. And then eventually they kind of scale and break down a little bit, and then they'll leave like a little ring of dry skin around it. But we're still talking about a very small little pin, maybe 2 to 3 millimeters, which is maybe a little under 1/4 of an inch. And then eventually they fade and look kind of brownish. And then they gradually just fade away over weeks or months.
Yeah.
They don't need any treatment.
Yeah. And they just go away. Just reassurance is all that you need. The only thing I want to point out with this one is it may start out looking like a little blister. And some little blisters, especially if there's like a cluster of little blisters in one area, could be a sign of HSV or herpes simplex virus, which can be very dangerous for babies. And so if you do see a cluster of blisters, that's probably one that you want your doctor to check and just make sure that there's not something else going on. But these usually aren't like just in a little cluster. They're a little like scattered,
yeah.
Not really just all in one little area.
And infants can be born with these also. So we tend to think of these as something that happens after birth. And classically they'll get that little pustule, to use your term, and then you'll get that little brown spot a couple weeks later. But there are kids who are born with just these little brown rings, which freaks parents out. And so they probably had the little blisters inside of mom.
And they're going to go away.
Yeah.
Over time. Our next one is milia. Alex, what are milia?
So milia, by definition, means milk spot. So, and they look like little drops of milk, like really tiny drops of milk that you get. And there are various varieties of it. So we're talking about the infant variety, but essentially it's trapped dead skin cells that build up into like a small lump. You'll see it in older kids. You actually see it in adults also, these little milk spots where it could be in an area where you sweat a lot and just don't have good, clearance. In infants, it tends to be on the nose and right underneath the eyes. It's really common. It's kind of cute. And most parents think it's cute and just kind of clears up on its own. And I'm going to say probably half the kids I see have milia.
Yeah. It's funny that there's all these, so that I would still consider that not plain language milia. And a lot of these things that we're going to talk about, there really is not plain language equivalents for these things, which makes it difficult. So I think as pediatricians, we just say, yeah, that's milia. Don't worry about it. It'll go away.
I actually tried milk spot for a couple families, and then they thought it was caused by the milk. So I've given up on that. So now I just call it milia, and they say, this is what causes it. So
because the next thing
I don't think there's an easy.
They're saying, they're allergic to milk.
Yeah, seriously. So they want it swiped because they have the milk spots. So
Now another term that sounds a lot like milia is miliaria. What is miliaria?
So again, it can happen at any age. I think the best description is a prickly heat rash. I think everybody knows what a prickly heat rash is, when you're getting all sweaty and then all of a sudden you get this like irritated skin underneath. And you don't see it in February, but it's 75 today, so we may see a prickly heat rash in the urgent care sometime this weekend. It's essentially a backflow of your sweat gland. So the sweat gland is trying to get rid of some of the sweat, and that duct, the little like tube from which the sweat comes out, is blocked or kinked in some way.
Yeah.
In adults or bigger kids, it's because of development, thick skin, perfumes, moisturizers, or whatever. In kids, it tends to be heat related because now they're sweating a lot and the sweat glands can't keep up. And in infants, we think it's just the duct has not developed yet well enough to kind of produce the sweat. So they look like these raised, almost pimply red things on the body. I like the term infant acne. I know we're not supposed to use that, but a lot of parents like that term because that's the way they kind of get used to calling it. But again, it's something that's going to clear up on its own. You don't have to use any medicine. In fact, the best medicine is just to not do anything with them. Yeah. So, and like we talked about before, if you see a cluster of them or they look angry, then you worry about a herpes infection.
Yeah, yeah. Or a cellulitis or an impetigo, a skin infection, whether it be infected with virus or with bacteria. So, and I always say, even though we're describing these things, like if you're concerned about your baby, have your pediatrician look at it. I mean, the reassurance is a thing.
And now phone calls, like taking pictures on the phone, we have my chart here. I think a lot of places is something similar. Just send us a picture. And most times, like, okay, this looks like classic miliaria.
And as pediatricians, I find that actually really rewarding, reassuring people. So, like, and then I feel like then the parents always apologize because you're saying like, no, this is a normal baby thing. It's going to go away on its own. And then they're like, oh, I'm really sorry I wasted your time. Like, no, you didn't waste my time at all. This was really valuable time.
Yeah, we like doing this. Yeah.
We do. Yeah. I love reassuring and educating parents. It's really, really, I think, a rewarding part of being a pediatrician. Okay, the next one sounds really terrible. Erythema toxicum. Anything with the word toxicum in it doesn't sound good.
It does sound scary. So let me demystify, de-scary it. And I don't know why, but it's actually one of my little favorite diagnoses for newborn babies. So erythema means red. Toxicum does sort of mean like toxic or irritating or bad. But this isn't really bad or irritating or it doesn't hurt. These are pretty darn common, and they usually show up within a few days of a baby being born. So they maybe aren't there when the baby's born, and then a few days later, oh my goodness. And I describe them as almost they're like little tiny, they're not clustered blisters. I don't really want to call it a blister because that's a thin thing, but like these little tiny pimple things. Oh my.
That's a good way to put it, actually.
Pimple things.
Pimple things.
Okay.
And I think these sometimes get called baby acne too.
Yeah.
Just because they do look like like pimples.
I always think there's a little bit of a yellowish tinge to them, and then they're on a little red base. So they're readily recognizable when you know what they are. And it's just like you said, it is so wonderful to be able to reassure a parent that this is a normal variation. Sometimes they come and go for a while. They will fade away, and they don't hurt. They're not hurting the baby. They're not an infection. And I, you're just talking about what to call it. I will often write it down for them, the whole erythema toxicum, because it's a mouthful, but that is the words for it. Those are the words for it. And I still remember one time a father brought a baby in, and he had to go home and tell the wife, who was probably at home with 3 other kids or whatever. I don't know where she was, but he had to be able to tell her what it was. And so I spelled it out and then hopefully explained it clearly. And especially, nowadays people want to look these things up. So you don't want them to have to try to come up with the spelling as well. So,
and you also see it a lot when it's from the skin changing from your waterproof skin to more outside of the womb skin. And also when some of that lanugo, the fine hair, kind of comes off. And we're all trained by the books that it's only in the first couple of weeks. But, seeing a lot of patients from especially like East Africa or Southeast Asia where their lanugo can be on there for 6, 7, 8 weeks sometimes. We'll still see erythema toxicum at a 2-month visit. And I think that a lot of times when you just Google erythema toxicum, call your doctor if it's been there more than 2 weeks. And so I usually also explain, as long as they have that fine hair, that means that they still have some of that.
Yeah. It's like oil, you had mentioned before with Milia, like sweat getting stuck in and not being able to come out. Yeah. This is just skin oil that's stuck and not able to come out.
And the rule of thumb,
and body having a little immune reaction to it.
And the rule of thumb is you get the most on the face the day that you scheduled your baby's picture. Yeah. That's the way it always works. So,
exactly.
So if you want the max day, schedule a picture, and then that's when it peaks.
All right, Marianne, let's talk hemangiomas. And the technical name is a capillary hemangioma, but they're also sometimes called strawberry hemangiomas. What exactly are these things?
Yeah, I think part of the new term is infantile, meaning baby hemangiomas. So a hemangioma is like a cluster of little blood vessels. So that's the hemangioma part of the name. And they can look they can have a lot of appearances, but the strawberry hemangioma, that we don't have to worry too much about. These are characterized by not being there when the baby is born, and then starting to appear maybe a month, maybe a little after, and they grow really quickly. So suddenly they're very relatively prominent, and everybody worries. Oh my, is something wrong? When is this going to stop getting bigger? What does this mean for my baby? And then it's also characterized by kind of peaking in its growth, and then eventually, most of the time, kind of stopping growing and fading away or involuting. So they're the ones that are above the skin and relatively dark red, and they're a little bit rough. So that's why they've taken that name of strawberry hemangioma, which is kind of a good description for it. And we have to look at those and keep an eye on them to make sure a couple of things. One, even if they're not a serious problem in and of itself, if the location is concerning, that's something that we would probably want a specialist to take a look at. And what does that mean? It means if it's maybe by their eye, so that while it's growing, it obstructs the baby's vision, and that's a really important time in their life when they are hooking up all the nerves between their eyes and their brain, and their vision is being established. We don't want something growing and pushing that eyelid down and making it hard for them to actually see things and establish their vision processes. And there are other parts of the body where it could interfere with function or be irritated a lot. If there was one, say, in a diaper area that's constantly being irritated.
Because sometimes they can bleed if they're messed with because of their little blood vessels under the skin. Yep. And so if you're getting recurrent bleeding, you may need to do something. If it's in the ear canal and maybe interfere with hearing, which is important then for speech development later.
Yep. Or nose and breathing.
Yeah.
Or, around the mouth or all of those areas. So those are something you definitely want to have checked out, and we will join you in keeping an eye on them. And now, that, depending on what kind of hemangiomas they are, there are better treatments than there used to be. So we're probably more likely to refer a child if we have a concern like we've just been talking about earlier rather than later. For treatment.
And then you can have very large ones that are rare, like they're called cavernous hemangiomas that can be more problematic. And there are definitely way more treatments than when I was training. But there's laser treatments, there's topical medicine, there's oral medicine that could potentially be used for these. But again, that's all going to be a dermatologist that's
in a lot of places like us, we actually have a hemangioma clinic. I mean, it's common enough that we have our own clinic, and a lot of the children's hospitals have their own clinic just because it's an art form just to kind of figure out how deep they are and how to treat them. But
it's really exciting because we do now have good treatment. We used to not really, that we're not really invasive or...
But small ones that are not interfering with function, that are not bleeding and irritated. The key take home is that these are going to get larger during the first year of life and then usually get smaller over the next several years, so that by the time they're school age, they're way less noticeable. But again, that one size does not fit all with hemangiomas, and you want to have your doctor look at it and refer, when they're worried. All right. What about port wine stains? Now, this is great plain language.
Yeah.
Right?
Yeah. So
port wine stain.
I'm not sure how many of our listeners drink port wine, but it actually looks like the color of port wine. And this is yet another skin blood vessel kind of interaction, like of stork bites and also hemangiomas. So compared to the stork bites, which is called a nevus simplex, this is called a nevus flamus. And the difference is that in the stork bite, you can see those are like a pool or like a collection of blood vessels that act like typical blood vessels. So if the child screams or yells or is upset with a diaper change, it can get darker and then lighter because those blood vessels act like normal blood vessels. And then eventually the skin hides it as the skin gets thicker. Port wine stains are permanently engorged or enlarged blood vessels. So these are blood vessels in the skin that can't get any larger, but they don't get any smaller. So you essentially have this like vascular looking or blood looking appearance on your face that looks like port wine. So why isn't it completely red? Because the skin changes the color of overall, so you have that combination, you get that kind of color of port wine. These do not go away. And so these are more serious, and you have to take them seriously because it can be associated with a couple things. One is Sturge-Weber syndrome, where you actually have a port wine stain on the face, which can also affect or is there because of a neurological issue as the nerves developed on the face. So the rule of thumb is that if you have a port wine stain on the face that is anywhere near the forehead or anywhere near an eye, they should go see dermatology. A lot of those kids are going to get an ophthalmology exam just to make sure that the blood vessels behind the eye are growing well and you don't have pressure in the eye. And a lot of the kids are also going to get an MRI of the brain just to make sure that the vasculature, the blood vessels of the brain, are developing fine. So port wine stains they're there. And I commonly get dermatology involved, even if it's towards just near the jaw. I still want somebody looking at these things.
And some of them can be really large and really a cosmetic issue because they're going to have this their whole life unless you intervene.
And it grows with you. In other words, So they will get larger proportionally to the way your face is getting larger.
And there are laser procedure options that dermatologists, may or may not recommend depending on the location, the size, the parents' wishes. Some be like, no, my kid will be fine with this. And others will be like, no, I don't want him to have this. And there's not necessarily always a right or wrong answer about that.
Yeah, but I think, again, job number one for an infant, if you see a port wine, is I got to make sure your eye and your brain are normal.
Yeah.
And, so anywhere near the forehead, anywhere near an eye, you're going to go to dermatology. And not for cosmetic reasons, but just to make sure that you don't have something deeper going on.
Yeah, absolutely. All right, let's move away from the skin and talk a little bit about a baby's head and hair. Babies, oftentimes, you had mentioned that they often get squeezed in the birth canal, and so you can see sort of misshapen heads and bruising of the head, especially immediately after birth.
Yeah, so one, they'll have that sort of vernix, that greasy thing on top of the head, because most kids are going to fly out head first. They're going down a slide head first. But you get something called molding, and the head is developed with a lot of little plates, which have what we call suture lines. It's almost like plate tectonics in geography class or geology class, where you sort of have these parts of the world kind of fit together. Same thing with the skull, where it's a bunch of little bones that eventually all fuse to produce our skull as we get into adult years. But you have something called molding, where to squeeze out, we're designed to kind of have those bones come to an area so you can come out of mom. You're looking at a 10 centimeter opening, and most kids' heads are probably going to be, once they round out, more than 10 centimeters. So they have to do this to kind of get out of there. If you have a bit of a bruise on top when you're first coming out, because that's where you're sort of producing mom's cervix to open up, then something called a caput. And caput essentially is a sort of bruise on top of the head has been the one that's kind of been leading the charge to open up the canal to come out. If you have a bleed, and something called a cephalo, meaning head, hematoma, which means blood collection, and those can be larger, and the caput tend to be almost like a coin-like shape at the top of the head. The cephalohematomas are a larger bleed. They tend to be on one side, and they tend to be over just one of the plates of the skull.
Yeah. And this is not a brain bleed. This is a bleed. A blood vessel got squished between the skin and the bone and just bleeds into the skin.
And caputs usually just watch. They turn some ugly green colors and all those goodies, but it doesn't really give you much harm. A cephalohematoma is a bigger blood collection, so those are children that you have to kind of follow longer for issues of jaundice or yellowness. So that's, if I see a child with a cephalohematoma in clinic, I usually bring them back pretty quickly, or ask the parents to kind of monitor and send me pictures if, to make sure they're not getting too yellow.
Yeah.
And the jaundice connection is because as the blood in that hematoma, that blood collection between the skin and the skull, as that starts to break down and absorb, the body breaks those blood cells down and it releases hemoglobin, and all that enters into the bloodstream, and that is processed by the body, leading to bilirubin and that yellow color.
Yeah.
So,
and that's well said, because, and that's what you're really worried about. So it's a little bit later than the typical jaundice after birth.
Yeah.
And the last thing I was going to mention about the head is something called fontanelles or soft spots. I think everybody knows about the front soft spot, but depending on the cultural background, it can be as much as 8 out of 10 kids have a posterior or back fontanelle. In some cultures, it can be, or nationalities, it can be 1 out of 10, but you'll see it in about half the infants. It's much smaller than the front or the anterior fontanelle, but they're still there. And that's the place where the brain's growing. So you actually want that soft spot to help. And you can touch it. You're not going to like pinch it on the brain. So parents get freaked out.
Yeah, absolutely. This is a little bit later, not in the immediate newborn period, but I just did want to point out that when those plates that you mentioned that kind of make the fontanelle, because there's different plates that then have to fuse, because the brain is growing rapidly, and so your head has to grow rapidly, and so by having these plates, that helps the head to be able to do that. But if they join together prematurely, you can get something with a really big name called craniosynostosis, and we have done episodes, a couple of them, episode 440 and 368, where we talk about abnormally shaped baby heads and syndromic craniosynostosis. And so if you're interested in learning a lot more, I know, not plain language at all.
Yeah.
But that's what it's called. But we're breaking it down. It's, those plates fusing too early, too soon.
Cranial means head, syn means come together, and osis refers to the bones.
Yeah. So, Marianne, that is fabulous. That is exactly right.
And I want to say these plates that we're talking about are not dinner plates. These are plates of bone, flat, flat kind of like, I liked your analogy of tectonic plates.
Yeah.
If you're an earthquake type.
Yeah, I like that a lot. So we'll put the links to those episodes if you are interested in more about soft spots and bones fusing together on time or too soon.
And I'll do real quick on hair, because you'll have blood in there, you'll have other goodies in there, you'll have fluid coming out in that hair. So rule of thumb is that the hair is going to be looking kind of gnarly when it comes out, and the color you have coming out tends not to predict. So if you have a blonde coming out and mom and dad are not blonde, it's probably going to get more dark. Some kids are born with very little hair. Some kids are born with a ton of hair. Some kids are born with hair that doesn't fall out all that quickly. So some have hair that falls out really quickly. So hair is very variable and is very unpredictable as far as predicting what's going to happen. So rule of thumb is enjoy the hair that you have at the moment and then take pictures, but there's a good chance that if you're both brunettes, then there's a good chance your child's going to be also. So having shocking red hair, it could have been the blood, it could have been whatever, and then
it can change.
It can change.
And not only the color can change, the texture, the thickness, how coarse it is, whether it's straight or curly, all those things can change.
Yeah.
What about eyes? They change as well, correct? Some do.
Yeah, eyes do. It's kind of surprising. Everybody is like, oh, what color are their eyes? It's really hard actually to see newborn babies' eyes. So I don't know. Although I remember our daughter, right after, several hours after she was born, she had these big, bright purple eyes. But that was probably a coincidence or just good luck, because it's especially when we go in to examine a newborn baby, maybe the next morning or whatever. We really have to get a good look at the eye, not the whole eye, but a couple things that I'll talk about in a minute. And it can be really hard to get a good look in their eyes because they're not usually wide-eyed and awake, and sometimes there's a little bit of mucus and crusting, and so it's important to look at the outside. Make sure there's no blisters or redness or anything like that, and roughly the shape of the eyes and the position, that they're not too close together or too far apart or slanted or different sizes. So it's always good to be the same on both sides, symmetry. And then, again, a little bit of crusting and mucus can be normal if there's a lot, and that usually happens a little bit later. We think about a blocked tear duct or something like that. If a baby opens their eyes and kind of looks around, they're not really able to focus or see anything right away, but you can at least kind of get a sense of that their eyes are both moving in the same direction, and we want that to be the case. The thing that we pay the most attention to is really getting a good look with the ophthalmoscope, which is the instrument we use to look in the eye, to make sure that we can see what we call the red reflex. So you have the white part of the eye, which is usually white. Sometimes it's kind of a pale blue. And then you have the iris, which is the colorful part. And hopefully that's those two irises in each eye are the same size and the same shape, and they don't have any little notches in them. And then that middle part, the black part or the pupil, we want to get a good look through the outside that you can't really see, the cornea, to look through the pupil and the lens and see into the back of the eye. And what we really want to see is what we call the red reflex, which when we shine that light in there, we see a reddish or an orangish round appearance that looks pretty clear.
Yeah. In the days of the original digital cameras, you would get the red eye.
Yeah.
Now a lot of times they
erase
cancels out.
The computer chip in the camera will get rid of that. But that's what we're seeing, just light from the flash or ambient light, room light that goes and hits the retina, which is filled with blood vessels
in the back of the eye.
And then that light comes back a red color because that's what color the retina is. And so if you don't see the red reflex, that means that there could be something in the eye blocking the path of light to the retina, like a tumor or something, which can happen in kids.
Or a
babies.
cataract. Believe it or not, babies can be born with a cataract, or they can even have glaucoma when they're little, and it can be kind of hazy. So anytime we see one eye different from the other on that red reflex, or the haziness or something getting in the way of seeing that, or a white or a pale gray, that we call the eye doctor right away. Yeah. And the baby needs to be seen very quickly.
Yeah, absolutely. And if the eye is a darker color, it's more likely to stay that way. We talked about color change. It's the kids with the really light colored eyes, like blue, that if they get to be 6 months of age and it's still blue, maybe it'll stay blue, maybe. But those blue eyes can sometimes get darker. Yeah. All right, let's move down to our baby's chest and tummy. And Alex, what do we need to know here?
So I'll keep it shorter. So chest is thinner. They don't have a lot of muscle. So you can feel the heart beating, or it seems like a heart's beating right next to the skin, because it is. And they're beating quickly. So just to kind of warn the parents that they may be beating 100 plus times a minute, and it may seem like they're beating too hard. But as long as the child's peeing okay, looking around, is just because the heart's right next to the top of the rib cage, and there isn't a whole lot between the rib cage and you hearing it. And then also breast development happens in a fair number of kids. I'm going to estimate is anywhere from 10 to 30% are going to have some breast development, and of the ones who have breast development, some will actually produce a couple drops of what looks like milk, and it is actually like milk. And that's normal. And it's from the estrogen effects or a hormonal effect from mom. It can take, the milk goes away pretty quickly if you see that. And that's like 1 in 100 kids or 1 in 200 kids. But the breast development, like 1 in 3, potentially, depending on what you're seeing in clinic, that can take several weeks to several months sometimes to clear. I start to worry if the breast turns red, painful, or one side just seems to be larger than the other side. Then you're starting to wonder if this may be just not a hormonal effect. This actually may be something wrong with that breast.
Yeah. And you can see that in girls and boys.
Yes, you can.
So boys' breasts will respond to mom's estrogen, but after birth, they're not getting any more estrogen. And so eventually that goes away, that hormone goes away, and then the breast development
and then
goes back the other way.
Yeah. As far as the tummy, so mention a couple things. First is we have our 6-pack, and I think everybody has a 6-pack. Mine's kind of shy, doesn't show itself really well. But there's the 6-pack is the muscles on both sides, and they meet in the middle, and there's this ligament there called a fascia, and what the muscles attached to that fascia, and then when you contract those muscles use that fascia to kind of like hold on to, like to grab onto. In infants, that fascia will have a little bit of a, not so much separation in that little like line or the fascia. It's just that the muscles don't come in at the angle that you would in like a bodybuilder, where the muscles actually are on top and the fascia is buried in. In kids, it's almost what we call filleting, where you kind of split like when you fillet a fish, you basically take a fish and split it in half. So the technical term is you have a filleted abdominal wall where those muscles are kind of like flipped out a little bit, and you'll actually feel like a indentation going from the bottom of the rib cage down to the belly button, and that's called a diastasis recti. I have no idea where that name came from, but it's just essentially a normal sort of separation. It doesn't mean that your gut's sticking out. It just means that there's a gap where the muscles should be touching the fascia, but they're not touching the fascia completely. So that's the first thing. That's pretty common. And I looked it up, there's really no data of when this closes. So nobody's actually looked at this, but I think all of us can agree, probably like age 3 or 4, you rarely see it anymore. But there are some adults that still have a little bit of a diastasis. And then the other thing to mention is the umbilical cord. Umbilical cords do need good care. And the important thing is to follow the directions from the Well Baby Nursery. Look for redness. If it's what we call foul smelling, where it just looks funny and smells funny, get it seen to make sure it's not an infection. Been at this for 33 years now, and I've seen what we call an umphalitis, or infection of the umbilical cord, I think 4 times, and it's like literally like every 8-9 years. I'm not sure how many you've seen.
Handful, not a lot.
It's not many, but you always worry about it, because that it actually is a high mortality infection. In other words, that's an infection that can lead to like a serious infection very quickly. So I ask the parents, if you have any concerns about redness or it just looks funny or smells funny, come on in, because you can't tell that over like a my chart. Yeah. And then when the umbilical stump falls off, which is anywhere from 5 days to sometimes 2 to 3 weeks, you may notice a what we call a hernia, where they actually have like almost like a little sausage thing coming out. And that's also normal. And a hernia means a defect in the abdominal wall, or a defect in a muscle. And the muscle in that area isn't completely closed. And what we'll do as pediatricians actually put our finger in there just to see how big that defect is. And if it's less than a centimeter, which is about the size of most people's pinky, then it's going to close on its own. If it's really large, like the size of somebody's thumb, the actual defect, not the actual sausage sticking up, then you basically may need to go to surgery. But most kids are going to have like a smaller size. And I just ask the parents to monitor that stump coming out to make sure it's not red, not painful, and goes back in when the child's not upset.
Yeah. And I think that's important. Don't tape a quarter over it. Yeah, that's like one of those things that like got passed on from great grandma to grandma. To, like if you tape a quarter over it, then it'll just stay in. But it's okay if it pops out, as long as you're able to push it back in. Yeah, in fact, but you don't have to push it back in every time it pops out. Yeah, in fact, the more you, once a day. Yeah. The more you play with it, there's some studies that it actually stays longer. So just let it heal on its own. Yeah, so just leave it alone. But if it's angry looking, or your child is angry, and it seems like it hurts, and it can be. I mean, it's really rare that it's really intestine that's poking out through there. If it gets stuck, it can kind of cut its blood supply off and be a problem. But that's going to be a really painful kind of thing, and that's a medical emergency. You would want to see something right away. You do ER, I do some urgent care. So in 30 some years of doing this, I've seen, I think, 2 what we call strangulated umbilical hernias, where it and you've probably seen not a handful. Yeah, I mean, literally, the 2 of us probably have like 50 some years combined, and you just don't see it much, but you always worry about it, because that's another thing that can it can lead to death. Yeah, so. Yeah, absolutely.
And I do want to just add, when we use the word defect here, we're not saying defective. A defect is a word that we use when there's an opening. In other words, what's normally there is absent, and so it's very easy for us to use, there's a little defect in whatever we're looking at. But that could be concerning to a parent. Yeah. I mean, we may be like, it's just a little defect. It'll be fine. And then from the parent point of view, what? I have a defective baby? And then they have to go home and explain that to the rest of the family. Yeah. The doctor said the best one I heard is like, a donut is essentially a defective big piece of gooey goodness. So, donut that has a whole donut. Yeah. So donuts have a defect in them. So the baby has a donut until the donut hole comes in and fills it in. So I think that's like a little more. It's a little opening. Yeah, I like that. Let's move down to the diaper area. Marianne, what do we need to know down in the private parts? Well, I was focused mostly, as I was thinking about this, on diaper rash, because so much of this is like, what do you see? And the non-plain language term for diaper rash, I just think it's priceless. It's irritant contact dermatitis. Wow. Oh, my goodness. So irritant, it's such a great term if you know what those words mean. So irritant means the skin in that diaper area is irritated. Contact means whatever is irritating it has actually touched the skin and either rubbed on it or been on it too long, or is irritating in and of itself. We'll talk about that in a second. And then derm is skin, and itis means inflamed or more irritated. So you've got inflamed, irritated skin because of something rubbing on the skin or being too close to it for too long. And usually that is related to diapering. And it doesn't necessarily mean that if your baby has diaper dermatitis or diaper rash, it doesn't mean that you're not caring for your baby's bottom well. There's a lot that goes into the baby's skin as it's growing and maturing. And as Alex said early on, the skin protects and covers the baby, and it needs to be smooth, not necessarily smooth, but it needs to be, the word we would say is intact. It needs to be not have little holes in it or hard to see, but openings in the skin. So some babies are more sensitive than others, but if they're exposed to the urine and the poop that's in a diaper, even if it's not for a long time, but if, say, those diapers aren't changed quite as quickly as they should be, or you don't have like an ointment to create a barrier there, or some people are overly concerned about keeping their baby's bottoms clean, so they will scrub and wash and use a little elbow grease maybe and some irritating cleansers. All those things kind of break down the natural barriers to the skin protecting itself. And then you get little tiny openings, irritation, redness, the body fighting that irritation. And then depending on how bad it is it a mild diaper rash, or has it gotten so bad that it is just painful for us to look at? And couple other things about it, one of the ways to tell if it's just a diaper rash or something more, usually the diaper rash is on the surface of the skin, the places where the legs connect to the trunk of the baby, the creases are usually not irritated as much because they're kind of protected by the baby's skin fat coming together, so that irritation doesn't get down in there. Sometimes the red areas can get so irritated that they're vulnerable to getting an infection from the normal bacteria that are in our environment, like strep or staph, or the yeast that's around, and they can get what we call a secondary infection on top of that diaper rash. So if your baby has diaper rash, you want to keep that area clean, dry, open to air as much as you can, and then clean maybe just with a gentle warm water and a clean cloth without or wipes that don't have perfumes and extra stuff and fragrances in them. Just keep it simple and plain. And then use a really good ointment or like petroleum jelly or a zinc oxide to create a beautiful barrier against ongoing irritation.
Yeah. So the pee and the poop don't touch the skin.
Exactly.
They touch
Basically,
the ointment instead.
Yeah.
And then if it does get one of these secondary infections, there are either some antibiotics that we can put either on the skin, or if it's more severe, take by mouth, or if there are creams and ointments that we can use that may fight that yeast infection if that happens as well.
Yeah, absolutely. Let's also just briefly talk about baby genitals, especially in the newborn period. In terms of the girls, just like you can get breast development, sometimes little girls will have a little bit of spotting blood, like a little baby period. And again, that's just from mom's hormones. And as long as it just is brief and not very much blood, we don't really worry about that. Just something that we monitor. And then in the boys, you can get a loop of intestine that comes down into the scrotum. That would be a hernia. So if there's a swelling in the scrotum, you want to let your doctor know about that. And if they seem fussy with the swelling, that's could potentially be an emergency. So you want to let someone know right away. And then you can also get just some fluid inside the scrotum called a hydrocele, which is just some fluid around outside of the testicle, and it can make the scrotum look a little bit bulged. But babies, it doesn't seem to bother them at all. And, you can have your pediatrician look at that and let you know it's just hydrocele. It's likely to go away on its own.
And then you want to make sure for little boys, especially where the urine or the pee comes out when they pee, to make sure that the opening is at the tip of the penis and not underneath, because sometimes it can not be lined up correctly. And you want to hopefully at some point make sure that they have a really good stream. When a diaper change is happening is often a good time for that to be experienced and observed.
Yeah.
So just to make sure that all that development has been normal.
I was going to mention two more things. So some girls are going to have what we call clitoromegaly, where the clitoris seems to be a little large. Let us take a look at it, because it can be a sign of a hormonal issue, but most times it's just because of the extra hormones from mom coming through. That's something, again, we'll talk about at the first visit. And then if a child gets circumcised, it does turn weird colors like yellow and gray. And there's some great websites out there in terms of this is what it looks like day 2 and this is what it looks like day 4. But when in doubt, it smells different. It looks really painful. Come on in. But there are some changes that can be scary. So, there are sites out there that kind of predict it. And a lot of urologists or a lot of baby nurses are going to give you like a little handout. This is when you worry.
Yeah.
So.
And if your child is not circumcised, just leave the foreskin alone. As long as your child's making urine in the newborn period, just let it be.
Yeah, I agree.
You don't need to do anything. All right. Well, we have talked for nearly an hour and about just looking at your newborn. But I think these are really important things because they're very common, and babies don't come with owner manuals, and new parents, aren't born with this knowledge. And so hopefully we have answered some questions today and provided some reassurance for folks. But again, if you have any concern about something you see in your baby, let your doctor know. You're never bothering us. We always end these with a little talk about primary care pediatrics at Nationwide Children's. Alex, remind us how large your network is.
We're, I think, the largest academic center-based clinic system in the country. So we follow I think we're up to 150,000 children that we follow that come to currently 15 unique clinics. I think adding number 16, or soon onboarding number 16, and some school clinics as well. And we have a mobile unit that goes to some places. So last year we had around 250,000 visits for the whole system. So it's a big system. It's a large system. There's about 80 faculty involved, and we take care of a lot of kids. And again, if you're in the area, and there's some really good pediatricians in the area as well, but if you need a pediatrician, then we usually have openings.
Yeah, and we'll put a link to primary care pediatrics at Nationwide Children's in the show notes for this episode 533 over at PediaCast.org. If you're in Central Ohio and you want to get connected to one of our primary care clinics, the phone number is 614-722-KIDS. That's 614-722-KIDS, and that will get you to our physician referral line to link you up with a primary care provider if you don't have one. And by the way, I've had people be like, wait, kids, what does that mean? Because not all phones have letters instead of numbers. And so I would...
That's right, yeah.
Yeah. So I would... I probably should have figured that out, what that number is. But just look at an old phone and you'll see letters in addition.
No, I don't have it, yeah. I was going to look at my cell phone. I don't have letters.
Really?
Yeah, I have no idea.
Okay, no, I have them. So KIDS is 5437.
Okay.
Absolutely. Yeah.
So we'll put a link in the show notes for primary care pediatrics. I also mentioned that Pediatrics in Plain Language survey and our Plain Language playlist over on SoundCloud. We'll put links to both of those things. We also have a link to the American Academy of Pediatrics has a site called healthychildren.org, and they have a page on how your newborn looks and also how your newborn behaves. And I'll put links to both of those in the show notes as well. Once again, Dr. Mary Ann Abrams and Dr. Alex Rakowsky, both with primary care pediatrics at Nationwide Children's Hospital. Thanks so much for being here and visiting with us once again.
Thank you both. Thank you.
Great to see you. Thanks.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast a part of it. Really do appreciate that. Also, thanks again to our Pediatrics in Plain Language panel, Dr. Mary Ann Abrams and Dr. Alex Rakowsky, both with primary care pediatrics at Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCast.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Or if you just want to say hi. I read each and every one of those that come through and love hearing from you. Reviews are also helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. Don't forget about our sibling podcast, PediaCast CME. That stands for Continuing Medical Education. It's similar to this program. We do turn the science up a couple notches and offer free continuing medical education credit for those who listen. And that, by the way, includes doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely we offer the credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of the episode matches your scope of practice. Shows and details are available at the landing site for that program, PediaCastCME.org. You can also listen wherever podcasts are found. Simply search for PediaCast CME. You may have noticed that on the weeks that we have a PediaCast CME come out, there's not a plain PediaCast that comes out that week. So we either do a regular one or we do the CME one pretty much every week. And I just wanted to mention that even though those CME podcasts are really geared toward providers and is definitely going to have more medical jargon in there, there are some topics that I think parents would be interested in. And next week is actually going to be one of those. So we are doing a show on caring for children with incarcerated parents. And that's actually kind of a big problem. There are as many children in the United States with an incarcerated parent as there are children with asthma. And so having an incarcerated parent is an adverse childhood experience for many reasons, and often goes along with other adverse childhood experiences. And we've talked about ACE scores before. The higher that is, the more toxic stress and the more hardships and challenges you're going to face. And so, it's really a great idea to get involved, even if you don't personally know a child with an incarcerated parent, to find out more about what their struggles are. And maybe you will find a passion in yourself to help those kids in some way. And so I would encourage you, if you're a parent with an interest in that topic, even though it's a CME episode, please do check it out. And again, that's going to come out next week. All right. And by the way, that's on the CME program again. So you'd want to search for PediaCast CME to find it. All right. I want to thank all of you once again for stopping by. And until next time, this is Dr. Mike saying stay safe, stay healthy, and stay involved with your kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast.